Well, hey there, future nurses. Welcome back to the Nursing School Simplified podcast. Today, we're going to be talking about angina or angina, depending how you pronounce it. But if you want to sound fancy, you say angina. So before we jump into that, I wanted to just ask you a couple questions. And they're not really questions, they're actual statements, but I want to see if you actually know that these are true statements. So, the first one, did you know that more people will die from cardiovascular disease this year than all the cancers combined? And that's men and women. And did you know that women, their risk for cardiovascular disease quadruples when they hit menopause? Now, if you knew the answers to those, give yourself a gold star, but it's pretty scary when you think about it, right? So we're all at risk for cardiovascular disease. Now, one component of cardiovascular disease is coronary artery disease. And this is an umbrella term that covers chronic stable angina and acute coronary syndrome. And under acute coronary syndrome, or ACS, we have unstable angina and myocardial infarction. So it's basically what the diagnosis is, right? It's disease of the coronary arteries. Now, I want you to think back to your anatomy and your physiology class, and I want you to think about where those coronary arteries are. Get a picture in your mind, and I want you to think about what those coronary arteries do. So the coronary arteries are located at the base of the aorta, and as that left ventricle pumps all that fresh, juicy, nutrient-rich, oxygen-rich blood into the aorta to go out into the system to circulate, correct? The very first things that get all that fresh juiciness are the coronary arteries, and those wrap around the heart and supply the heart with fresh blood and oxygen and nutrients to meet the metabolic demands of the myocardium or the heart. So when we talk about metabolic demands, we're talking about function, pumping, all that good stuff. So when the blood flow is altered in those coronary arteries, it's obstructed by plaque, and that is called atherosclerosis. And two things can happen here. So either it's blocked a little bit, so we just get a little bit of an occlusion, but there's still enough flow to feed the heart, but maybe not enough, and we call that ischemia. Okay, but it still can meet the demands, the heart's still functioning okay, but then we have severe ischemia, where we have cell death, and that is myocardial infarction. And this is irreversible. So ischemia is reversible. Severe ischemia leading to myocardial infarction is not reversible. And depending on your book, usually they say more than 40% is severe ischemia. More than 40% blockage is severe ischemia. So what nursing diagnosis would you think would apply to a patient with coronary artery disease? If you said decreased myocardial tissue perfusion, you are right. So we classify risk factors into two categories. We have modifiable and non-modifiable. And just like they sound, ones you can fix and ones you can't. So our modifiable risks are things that we can control: diet, exercise, stop smoking, weight loss, stress reduction, consume, and reverse or tightly control your diabetes and hypertension, and get enough sleep. Sleep is so vital to our health. Now, our non-modifiable risk factors are basically two things. One, your genetics. So say thank you to your family, and your sex. Now that we've done a little bit of that background, now we can get into angina. So angina is chest pain, okay? And there's 3 different classifications of chest pain. The first classification is chronic stable angina. And this is chest pain that occurs with activity, and the frequency and intensity remains the same over a period of time. So it could be several months, it could be several years. Now, this type of chest pain is relieved by rest. So they stop doing whatever it is they were doing. And sometimes they will be taking nitroglycerin. And they might have other medications that they take as well. So the key point of the chronic stable angina is that it's chest pain that occurs with activity. It's relieved by rest or nitroglycerin. So the thing about chronic stable angina is that it doesn't really require aggressive treatment at this point because it's chronic, it's stable, and it's predictable, and it remains treatable. However, it can progress into unstable angina. Now, in unstable angina, we have chest pain or discomfort that occurs at rest or with exertion, and it causes severe limitation. So the pressure can last, or chest pain can last, longer than 15 minutes, and it is not, and I repeat, it is not relieved by rest or nitroglycerin. Now, when these patients present to the ER, they typically have ST changes in their 12-lead EKG, but they may not have detectable lab changes, specifically troponin, because the ischemia is not severe enough. So we're still going to treat these patients pretty aggressively. They usually end up going to the cath lab, and depending, they could get a stent, and just depending what the doctor wants to do. And then they usually end up on additional blood thinners. And then our last one is Prinzmetal's angina. Now, this one is chest pain due to a coronary artery spasm. And this can happen at rest, and it's usually triggered by things like emotional stress, medications, street drugs like cocaine. So tell your patients, don't do cocaine. And sometimes exposure to cold. And we're going to treat this with nitroglycerin and beta blockers. And we just want to make sure that those coronary arteries are open, and we just follow this patient. There's really no aggressive interventions for these patients. Now, that's it for those 3. That's all you need to know for angina. Now, I want you to think about how you would assess these patients, and what kind of questions would you ask them? What interventions might you perform, and what would you teach them? These are the things that you should be asking yourself when you're studying, because this is how you develop critical thinking skills. Just like anything else, it takes practice, but if you make it fun, if you make it a game, these concepts will come to you a lot easier, and they'll be easier to remember. Now, what I used to do, I would play a little game with myself, and I would say, what would I teach this patient? And then I would write down as many things as I could think of to teach the patient. And then I would go back and check in my book and look and see if I got them right. And specifically the ones that I missed, the ones that I forgot about, because those are the ones that I needed to make sure I remembered, because it just seemed like my luck, those would be the ones that always pop up on a test. So it's a lot of fun if you do this with a partner. So if you have a fellow student that you like studying with, or a group of students that you study with. This is a good exercise to do as a group when you're studying a disease process, and to just put the question out there: what would you assess? And let everyone have an opportunity to answer. And I'm telling you, this works for auditory learners, this works for visual learners, this works for tactile learners, because you are involving all your senses and you're going to remember the content more. You're going to remember it better. You're going to be able to recall it easier for your exam. So try this with your study group, try this with a study partner. I guarantee it's going to work. So I want to thank you for listening today. And I want to leave you with this final thought. True fulfillment in life doesn't come from what we get. It comes from what we give. Until next time, have a great day and keep working on your dreams.